So this is a very intensely itchy eruption. Patients develop papules, vesicles, nodules. And remember that scabies can present in different ways. So if you look at the blue box on the right, the classic presentation of scabies, which is the most common form, is those patients presenting with severe itch. They may be tired because of sleep disruption. They tend to have a lower parasite burden, and they have the very characteristic features which we'll look at in just a minute. The crusted form of scabies, also known as Norwegian scabies, is a form that we see typically in immunosuppressed patients or those that may have neurologic compromise. This is a form where you have a very high parasite burden. One scraping, we can see 10s, 20s, 30s, sometimes hundreds of mites under the microscope. This can be associated with lesions that aren't characteristic for scabies, so it's often misdiagnosed, and hence it can be spread very easily. One example is among long-term care facilities. So these burrows are formed as the female mite burrows in our skin. Remember that they then lay down the eggs, which hatch into new mites. And the itch with scabies tends to be worse at night. Here's some pictures showing the typical lesions. If you look at the left panel, that really shows the linear burrows you can see in the web spaces on the hand. The middle panel shows that hypersensitivity, very papular eruption. And on the far right is a really sine qua non of scabies, which is any erythematous papules on the penis of a male should be considered scabies until proven otherwise. Now, there is a typical distribution pattern. Think about fingers, web spaces, wrists, elbows, knees, the groin especially, genitals, especially the penis in males, as well as the belt line and the axillary regions. And then in females, the nipples, the areola, are really common sites of involvement. In infants and young children, one area I always teach fellows to look at is the palms and the soles. Crusted papules on the palms or soles in a child is scabies until proven otherwise. Infants and children also get involvement of their scalp, their head, their face, their neck, which is much less common in older patients. So always think about those areas of involvement. And then in the blue box, you see nodular scabies. This is a form of scabies which tends to be unique to children and mainly younger children, infants and toddlers. And this is where they develop a really vigorous host immune response against the mite. This results in very itchy and very persistent erythematous papules and nodules. And you can see several of those nodules in the photographs I'm showing you here on the bottom of the slide. If you look at the photograph on the far right, the lowermost lesion, you see a red flare around the nodule. That's a pseudo-Derrier sign. Many of you know the Derrier sign is something we look for in mastocytosis, but with some patients with scabies nodules, you may have a positive Derrier sign as well. Other images from the pediatric world. So here you see palm involvement, and notice that you have a lesion right there in the fold of the palm. So for those of you who may do scrapings for diagnosis, we'll talk about that in a minute, going for the natural creases of skin is going to be a higher yield if you see lesions there. The mite kind of falls in to that little crevice. The foot on the upper right shows you multiple linear burrows, as you can see. And on close-up of the hand in the lower right corner, again, you can see multiple linear burrows. Remember that the mite is at one end of that burrow, and scraping through that burrow is one of the highest yield areas we have for doing mineral oil scrapings on the skin. Here's a prepubescent boy, and you can see on the penis, he has erythematous papules and nodules encrusting on the distal penis, on the foreskin, and on the glans penis. So that is scabies until proven otherwise. This also reminds me that a really common location for scabies nodules is the scrotum. So if a baby presents with firm red nodules on the scrotum, think about scabies nodules. Even though we have an accepted practical system of diagnostic criteria, it's not really used by many practitioners, and that includes all specialties. So this diagnosis can be challenging, and often it might be delayed. So let's look at criteria for diagnosis. First off, we just talk about the clinical presentation of scabies. We just looked at the clinical lesions and the classic distribution pattern. Hopefully that will bring you close to making the diagnosis. I always joke with my trainees, this is an across the room diagnosis. When I walk in the room and see that infant on the table with these very polymorphous crusted papules on exam, and maybe a parent who's sitting next to them scratching their wrists, we know we have the diagnosis of scabies. We'll look at the Burrow ink test and the topical tetracycline test, and then we'll look at other confirmatory testing, including light microscopy images and dermoscopy, which I realize many of you may not use. So physical examination and history is very important. Think about itch, ask about family members in the household, because again, this is highly contagious. Look for that papular or papulovesicular rash. Crusted papules are really very significant for scabies. These two photographs show linear and serpiginous burrows on close inspection. You may not always see burrows. They're not needed for the diagnosis, but if you do visualize them, it's really a slam dunk for the diagnosis of scabies in most cases. Remember that infants are more likely to have involvement of the head, the face, the palms, and the soles. Always look in those locations. This is the burrow ink test. It's something of historical significance. I will say it's rarely performed now by dermatologists and even more rarely performed by family practitioners or primary care pediatricians, but it is very useful. This is where you take a washable marker. We would use the purple surgical marking marker that we use in the clinic, and you go ahead and rub over several areas that you suspect might be scabies lesions. Then you wipe off that ink with an alcohol prep, but the burrow is going to preferentially take up that ink, and you're going to see a linear or serpiginous burrow as you see in this photograph on the right. This can be very useful for those who have fewer lesions or where it's more difficult to visualize the burrows, but for some clinicians it's not practical. Topical tetracycline is something that I think even those of us who are dermatologists have less experience with, but it was a historically very interesting diagnostic test. This is where you take a tetracycline solution and rub it on the skin in these suspected areas, and then you use your Woods lamp, the same Woods lamp that many people used to use for diagnosing certain forms of tinea capitis. And you'll see a fluorescence that's a greenish color in areas where you have that tetracycline taken up into a burrow. Again, this is seldomly performed by either dermatologists or primary care physicians. The real confirmatory testing we like and still perform is that of light microscopy. And I realize that many of you as primary care physicians may not have microscopes or may not have time to really do these tests in the clinic, but important to know how this is diagnosed in a specialty clinic. The way we do light microscopy, though, is with the mineral oil preparation. This is where you take a drop of mineral oil, you put it right over a few lesions that have been identified to be ideal, like linear burrows. You scrape right through the oil with a number 15 blade. You do tend to draw a little blood when you do this test. You then smear that on a slide. I add a few more drops of oil to that slide and look under low magnification in the light microscope. The beauty of using oil is that the scabies mite is still alive. They're not killed by this reagent, so you can usually see them moving. You can also look just for eggs or feces. And if you see any of those three, you've made the diagnosis. I'll show you pictures of those three in just a minute. This can be somewhat invasive, as I mentioned, for a flailing or moving young child. I told you that you do draw blood. This can even be a little bit dangerous. You have to be careful and be experienced in performing this test. It can also be more time consuming, which for busy primary care practices isn't always available. It really depends on the experience of the person who's doing the test, much like a radiologist reading x-rays. So you have to select appropriate lesions, and you have to be experienced in doing the scraping to have a high yield. But it is the test that we use in our clinics. And then dermoscopy is something that those of you in primary care would not be using, but you should know about. A dermatoscope is a magnified light device that's kept in the pockets of pretty much every dermatologist now, because they're used for getting a magnified look in the clinic at melanocytic lesions, nevi, moles. However, it can also be used for a variety of other disorders, and scabies is one of those, where if you use the dermatoscope, you can see what's been called the delta wing with the contrail sign. The delta wing is the jet formation that is what the scabies mite looks like under dermoscopy, as you can see here in this image. And the contrail, the plume left behind of smoke that you see with a jet, is the linear burrow you can see in the skin. So this can have very high sensitivity and specificity in the right hands. Again, this technique is pretty much limited to dermatologists. Now, there are diagnostic criteria for scabies, so important to know this. You can see the table on the left shows these diagnostic criteria, and these were criteria that were designed by a group called the International Alliance for the Control of Scabies. You can see you can make the diagnosis of confirmed scabies with at least one of those top three findings listed as A1, A2, and A3. So that's seeing mites, eggs, or feces via any of several different techniques we just discussed. Clinical diagnosis of scabies can be confirmed if you have at least one of those B criteria: burrows that you see, typical lesions on the male genitalia, or typical lesions in a distribution with two features on the history, which we'll get to in a minute. Suspected scabies can be diagnosed if you have either typical lesions in a typical distribution and one historical feature, or both historical features with atypical lesions. And those historical features, which are so important to the diagnosis of scabies, are itch and a positive history of contact to somebody known to have scabies infestation. So the aims of these criteria were really to provide improved consistency and standardization of the diagnosis of scabies in our clinics, and that maybe these could be used also for research studies both clinical and basic science research, and in public health settings. A systematic review of diagnostic methods that are used by physicians, and especially those in therapeutic trials for scabies drugs, found there's really wide variety and there's no uniformity in the diagnostic methods utilized. Now, this photo in the right lower corner shows what we might see in the clinic when we're looking under the light microscope after a skin scraping, after a mineral oil prep. And you can see here on the far right a beautiful example of the scabies mite. And then following her are multiple eggs. Those are those larger ovoid structures, as well as clusters of Scibala. Those are the fecal pellets, and those are all those dark concretions you see adjacent to the eggs. So seeing any of those on a prep would be considered positive for scabies. So scabies is a disorder that really is marked for low rates of immediate or sometimes correct clinical diagnoses, especially among physicians or clinicians who have less experience. And there can be barriers to confirming a diagnosis. We just discussed several diagnostic methods, but many of them are not all that relevant to primary care practices, especially busy primary care practices. Some clinicians may lack a microscope within their practices, and there really is a lack of an accurate, objective, simple diagnostic test for scabies. We don't have that yet. It would be great if we did.